talk about room assignments. You know, a big part of your test could be making room assignments, right? Because that is a management thing, and the NCLEX lady wants you to know how to manage the clients on your unit. Well, to make room assignments, you must have med-surg knowledge. You must understand disease processes to answer NCLEX questions. So, here's a common rule for making room assignments. Like illnesses can be put in the same room together. Again, like illnesses can be put in the same room together. And you're like, well, I knew that. Let's see how we can apply this concept. So, if you've got two clients and both have the flu, you would rather them have private rooms, right? But if you had to, you could put them together. Be sure that it is the same type of flu. That should be stated in the test question. What about children admitted to the hospital with RSV? Yes, we want them in a private room, but could we put them in a room with other children with RSV? Yes, because like illnesses can go together. Now, TB, tuberculosis. There are different types of TB out there in the world, aren't there? Yes, and your teachers have emphasized to you that people with TB need to be in private rooms, right? Yes, and you know you always keep the door closed, etc. If the client comes out into the hall, they have to wear a mask, that sort of thing, okay? But if you ever have a question about TB and they have the exact same strain of TB, they could go in the same room together as long as we know they have the same type of TB. Now, what if we have two clients that have AIDS? Can they go in the room together? You see, we learned a basic concept. Like illnesses can be put together, and then we've got to use judgment. NCLEX is all about putting you in a bind about things. They do not want you to be so concrete that you just stick to the rule all the time, no matter what. So, what you have to be able to do is to take a basic concept and then be ready to be flexible. This critical thinking exercise is a good example of being flexible with the NCLEX. Both of these clients are immunosuppressed, aren't they? Yes. What is the only reason HIV-positive clients are hospitalized? People that have AIDS are not usually hospitalized until they develop an opportunistic infection. So, one client might have pneumocystis pneumonia, and one client might have cytomegalovirus. So, would you want them in the same room with each other? No. So, this would be an example when you would have to expand your thinking and be flexible and use judgment. You see, that's a higher level thought process. So, no. Clients that are HIV positive or with AIDS need to be in a private room. Now, let me put you in a bind again. You have a client with AIDS in a semi-private room. There are 2 beds in the room, and it's the only bed left on the unit. We've got 3 clients that need a bed. I'm going to force you to put somebody in the room with them. In your mind, you're saying, well, you just said they need to be in a room by themselves. I've got to put you in a bind like the NCLEX is going to do to see if you can use judgment. So, here are the 4 clients, and I want you to decide which client you would choose. Look at the question with me in your student book. You are caring for a client that is HIV positive in a semi-private room. Which client is best to assign in the room with the client who is HIV positive? Would you choose number 1, the client that has asthma? Number 2, the client that is 8 hours post-appendectomy? Number 3, the client that has bronchitis? Or number 4, the client with partial thickness burns? That's right. The answer is number 1. Asthma, because that's the only one that's not infectious, right? Bronchitis can be bacterial or viral, right? And you would never put a fresh incision in a room with somebody that's HIV positive or immunosuppressed, now would you? No, cross-contamination could occur. Okay, here's another strategy that I use to answer this type of question. When you are making room assignments or when you are giving a report, you have to pretend that the next nurse that will be taking care of the client is not very bright. I do not mean to sound ugly, but this is a great strategy to use when answering these types of questions because it will help you to decide what is most important. I know if I'm taking care of 2 clients in a semi-private room and one is HIV positive and the other has a fresh incision, I know I'm going to wash my hands in between touching the clients and putting on my gloves. But since I already know the next nurse is not very bright, I have to protect my client by never putting the HIV positive client who is immunosuppressed with a client who has an infection or an open wound. Now, I know it's painful, but we need to talk some more about priority questions. So, here's a critical thinking exercise. You are working in the emergency department and an 18-month-old comes in with a diagnosis of rotavirus. The child is severely dehydrated with no tears when crying and has not wet a diaper in 5 hours. The primary healthcare provider has prescribed D5 quarter normal saline with 20 milliequivalents of potassium chloride at 20 milliliters per hour per pump. What would be your initial action? So, you're checking the primary healthcare provider's prescriptions, and the first prescription says D5 quarter normal saline with 20 milliequivalents of potassium chloride at 20 milliliters per hour per pump. Now, what are you concerned about with this prescription? Well, we've already said that fluids are needed, right? Okay, when you listen to that critical thinking exercise, what are you worried about? Potassium. Why are you worried about potassium? Because they have not wet a diaper in 5 hours. So, you call the primary healthcare provider and say, look, I am not giving this baby any potassium until they start wetting their diaper, okay? So, can I just start the D5 quarter normal saline and call you back when they have output? We will not start giving the baby potassium in their IV fluid until they have started to void, wetting diapers. Is that what they want you to do? Yes. They write prescriptions all day long, and we have to be able to look at those prescriptions and find those that we question. They want us to question the prescriptions. Now, it's no fun, I know, to call the primary healthcare provider and question a prescription. But there's never anything wrong with seeking clarification. And you know, when you take a prescription over the phone, you're supposed to write it down and read back the prescription. And sometimes that gets on the primary healthcare provider's nerves, doesn't it? Okay? But you have to do it just to make sure. Rule: just because a prescription is a prescription does not mean that we are always going to follow it. We have to make sure that it is safe for our clients. Now, let's move on to another exercise. Let's say that you are the charge nurse on an adult med-surg unit. Since you are short an RN staff member, the nursing supervisor has sent an RN with neonatal intensive care experience to your unit. The nurse states on arrival, "I have not worked on an adult unit for 6 years." As the charge nurse, what should you do first? Okay, let's read the options and then we will discuss together. So how are we going to critically think through this? Number 1, send the RN back to the NICU and assign extra clients to staff nurses. Doing this is a waste of a valuable RN resource and a waste of money. Also, it does not solve the problem. This would be unsafe for both the clients and the nurses. Number 2, call the nursing supervisor and demand an RN with med-surg experience. If the supervisor had an RN with med-surg experience, would a NICU nurse have been sent to you? Number 3, attend the shift report before making assignments. This will allow the charge nurse to assess the situation and to make assignments based on client and unit needs. Number 4, assign the nurse to do UAP duties. Doing this is a waste of a valuable RN resource and a waste of money. So, now you are stuck with an RN with NICU experience. Oh joy, it's going to be a fun day. Read the second part of the question. Let's critically think through this. Remember that a nurse pulled from another unit should be considered a brand new nurse until proven otherwise. So, let's look at number 4. New admit diagnosed with adrenal insufficiency. This client is deficient in all steroids, glucocorticoids, mineralocorticoids, and sex hormones, at risk for fluid volume deficit and shock. This client is considered unstable and is not a candidate for a pulled nurse. Now, let's look at number 3. Adolescent client, 8 hours post-hypophysectomy. This client is at risk for developing diabetes insipidus. Sinus surgery is a little close to my pituitary gland. This client is better cared for by the experienced nurses on the unit. In number 2, the elderly client with unexplained syncope. The client is at risk for an arrhythmia or MI or severe electrolyte imbalance. The option tells you it's unexplained syncope at this point. So they need close monitoring. That brings us to number 1. 4 hours post-cholecystectomy client experiencing pain every 3 to 4 hours. An RN from any unit can assess a client's incision and give pain meds. This is the correct answer because this client is uncomplicated. See, this is an example of how they will put you in a bind. And this is stuff you can't just look up in a book. You have to use critical thinking and apply the knowledge you have in your head about each of the client's conditions. Since we had so much fun doing that one, let's do another priority question. Now, let's think back to when we were talking about a client with hypothyroidism. Read with me. The nurse is scheduled to administer the morning dose of levothyroxine to a client with hypothyroidism. The client reports a feeling of fullness in her chest. What is the best action by the nurse? What are the hints? Hypothyroidism, levothyroxine or Synthroid dose, fullness in the chest. Now, what content do you know? Well, clients with hypothyroidism tend to have CAD. That puts them at an increased risk for an MI. Women often exhibit epigastric pain as a sign of MI. Levothyroxine is a thyroid hormone which will increase the metabolism, which increases the workload on the heart. Remember, assume the worst. Let's look at the answers. Number 1, administer aluminum magnesium suspension, 30 milliliters. Is this going to help the client? No, an antacid will not stop a client from having an MI, will it? That is what you're telling the NCLEX lady. The drug of choice for an MI would be an antacid. If you administered this, you are assuming that the client has indigestion. On the NCLEX, you should be concerned with the life-threatening possibilities of an MI with this client. Number 2, administer the levothyroxine. I don't think so. This will make the problem worse. This is only going to increase the heart rate and blood pressure more. Please don't increase the workload on my heart if I'm having an MI. Number 3, obtain a 12-lead ECG. Now, this is a favorite answer for students, but if you select this, you are delaying care. What do I mean by that? First of all, this answer makes the assumption that a 12-lead ECG is what you would do first if the client has an MI. Is that what you learned? No, you learned oxygen, aspirin, nitro, and morphine, right? Then start an IV access. See, by obtaining a 12-lead ECG, you postponed care that the primary healthcare provider would have prescribed to fix the problem. So, the answer, number 4, call the primary healthcare provider, is the only nursing intervention that will fix the problem in this question. Because you know that levothyroxine increases the heart rate and puts an increased workload on the heart that has CAD. So, could this client be having an MI? Yes, and the only option here that will fix the problem, the fact that the client is having an MI, is to call the primary healthcare provider. Okay, great job on these critical thinking exercises. That's all for now, but we will do more in the lectures throughout the review.